I'm Robert L Spitzer, Chairman of the APA's Task Force on Nomenclature and Statistics. We have the responsibility for developing the third edition of the Diagnostic and Statistical Manual, DSM-III. I'm also Chief of the Biometrics Research Unit at the New York State Psychiatric Institute.
I'm Robert L Friedel, MD. I'm Associate Professor and Vice Chairman of the Department of Psychiatry and Behavioral Sciences at the University of Washington in Seattle, Washington.
The main purpose of our talk is to see how the proposed classification in DSM-III of affective disorders and related conditions differs from DSM-II and how it relates to the latest advances in our understanding of drug treatment and what kinds of patients are responsive to what kinds of drugs.
I'd be particularly interested in seeing how the new nomenclature in DSM-III overlaps with the criteria that have been evolving from the psychopharmacology research literature regarding the response to different types of antidepressants.
Let me briefly give the classification so we can at least be talking with the same terminology. One of the distinctive features of DSM-III is that we've grouped all of the affective disorders into one rubric called affective disorders. In DSM-II, some of the affective disorders, such as neurotic depression, was classified within the neuroses, and then some of the affective disorders that seemed to be related to long-term personality characteristics were placed in the personality disorder section. We have categorized all of the disorders in which there is a full depressive or manic syndrome into a group called the affective disorders. The first and most important group within the affective disorders is the group that we refer to as episodic affective disorders. The term episodic means that the patient generally has a period of being well, which is clearly distinguished from the episode of illness. Often the onset of the illness is rather sudden, but may not necessarily be. Now, these episodic disorders are distinguished from a group that we call intermittent affective disorders. The term intermittent is perhaps not an ideal one, but we have been unable to find a better term. We are talking here about patients who do not have a clear, distinct episode of illness, which can be distinguished from their usual functioning, but rather that they have periods of days or weeks when they are distressed in some way by depressive mood, and intermittently there are normal periods which may be from days to weeks. This category is perhaps similar to the concept of depressive character or hypomanic personality or cyclothymic personality, and whereas in the episodic affective disorders we have three major categories, that is manic disorder, depressive disorder, and bipolar affective disorder. In a similar fashion, in the intermittent affective disorders, we have three categories: intermittent depressive disorder, intermittent hypomanic disorder, and finally intermittent bipolar disorder. Finally, we have a residual category which we've termed atypical affective disorders. Now, we recognize that the term atypical depressive disorder in particular has been used in a somewhat different context, which I know you will be discussing in terms of its specific drug response pattern. We're using it only in the sense of patients who have an affective disorder, but it does not meet the criteria for either an episodic or an intermittent disorder. One example of that would be a patient with a chronic depression, but the depression is not a full depressive syndrome. Another example would be a patient, say, the atypical bipolar, where there has been a full depressive episode, but not a full manic episode. That is, there has been perhaps a hypomanic episode, and we would call that an atypical bipolar disorder.
It might also be useful for me to go over briefly the different types of depressive disorders which seem to be emerging from the psychopharmacology literature. First of all, there are patients who respond positively to tricyclic antidepressants. The characteristics of patients who respond well to tricyclic antidepressants are that they have unipolar depressions. In addition, they have vegetative symptoms of depression, which primarily are anorexia associated with significant weight loss, middle or late onset insomnia, some psychomotor disturbance, either characterized by agitation or retardation. They may have also anhedonia, that is the decrease in the ability to experience pleasure. Some studies have suggested that patients who have psychomotor retardation also have decreased urinary MHPG levels, and that these individuals also have a positive response to test doses of amphetamines. Other individuals who have a positive response to tricyclic antidepressant may have increased psychomotor function. These individuals may have either unchanged or increased urinary MHPG levels and have a negative response to a test dose of amphetamines. Now, there are also negative predictors for tricyclic response. Patients who have either neurotic, hypochondriacal, or hysterical personality types have been thought to be, or shown to be in the past, not good responders to tricyclics. Those with multiple prior episodes of depression, and those patients who have significant delusions have been shown to be not good responders to tricyclics. Also, some recent data suggests patients who do not run adequate plasma levels of tricyclic antidepressants, even though they have the positive predictors for tricyclic response, will not respond well. Another subtype of depressive disorder appears to respond well to monoamine oxidase inhibitors. These patients have been classified in the past as having atypical depressive disorders as defined by the following symptoms. They have typically an acute onset of their symptoms secondary to a precipitating factor. They have good premorbid personality. Their depression is mild to moderate. It's variable from day to day, and it's often masked by phobic anxiety. They have hysterical features, which have unfortunately been poorly defined in the literature. They also have somatic symptoms. They suffer from restless sleep, fatigue, and irritability, and their endogenous symptoms occur irregularly. A final category of depressed patients who respond to pharmacological agents are those who may respond well to antipsychotic agents. As already noted, patients with significant depressions who have delusions or hallucinations do not respond well to tricyclics. They typically also do not respond well to monoamine oxidase inhibitors. This leaves us with only the antipsychotic agents as far as pharmacological approaches are concerned, and some of these patients are reported to respond well to these agents.
I think it would be interesting to get into the details of the criteria for the DSM-III categories and see how they relate to some of the specific drug response patterns that you've mentioned. For example, to get into the categorization of a depressive episode or depressive disorder, which is then subdivided as single episode or recurrent, let me read the criteria for a depressive disorder. At least 4 of the following symptoms. 1, poor appetite or weight loss or increased appetite or weight gain. 2, sleep difficulty or sleeping too much. 3, loss of energy, fatigability, or tiredness. 4, psychomotor agitation or retardation. 5, loss of interest or pleasure in usual activities or decrease in sexual drive. 6, feelings of self-reproach or excessive or inappropriate guilt. 7, complaints of evidence of diminished ability to think or concentrate. And finally, 8, recurrent thoughts of death or suicide or any suicidal behavior. Now, one has to have 4 of those 8 symptoms. In addition, the period of illness must have a duration of at least 1 week from the time of the first noticeable change in the patient's usual condition. And finally, there are some symptoms which would actually exclude the diagnosis, and those are symptoms which suggest schizophrenia. For example, delusions of being controlled or thought broadcasting, auditory hallucinations in which either a voice keeps up a running commentary on the patient's behavior or thoughts as they occur. And if one of these symptoms suggesting schizophrenia are present, then the diagnosis of a schizoaffective disorder is more likely. Now, that is the opening to getting into a depressive disorder, and then we characterize the episode as either mild, moderate, severe but not psychotic, or severe and psychotic. Mild means that the patient merely has 4 of those 8 symptoms. At the moderate level, we require at least 3 symptoms from a list of symptoms which are suggestive of endogenous features. such as loss of interest or pleasure, distinct quality to depressed mood, lack of reactivity to environmental changes, mood being regularly worse in the morning, excessive or inappropriate guilt, early morning awakening or middle insomnia, psychomotor retardation or agitation, and weight loss. And I noticed that many of these symptoms, or some of these symptoms, are the same symptoms that you had mentioned as boding well for a tricyclic response. The next level is severe but not psychotic, and what is required here is evidence that the patient is unable to function at work or at school or to take care of the house, or is unable to feed or clothe himself or maintain minimal personal hygiene. And then finally, we have the characterization of psychotic, which is either delusions or hallucinations. So I would think that there is a rather close correspondence between the moderate or severe level and what you characterize as patients likely to do well on tricyclics. Now, the intermittent affective disorders, I think, has many of the features that you have described as being associated with the atypical depressive disorders, such as the reactivity, the lack of the persistence of the endogenous features.
Yes.
Now, the patients that we characterize as atypical, although it's a residual category for us and it's really defined by what it is not, I would suspect that many of the patients for whom this category would be used are patients that previously might have been referred to as neurotic or characterological depressions, and I suspect that many of these patients would also be the same patients that you mentioned as likely to respond to an MAO. So I guess my overall assessment is that DSM-III is a lot closer to having a correspondence to a psychopharmacological knowledge than DSM-II, but there is certainly not an exact correspondence as of yet.
I think there are a few therapeutic implications of DSM-III that we might want to focus on in terms of pharmacological response that may be overlooked. I think we've already mentioned a couple. The other factor that we really haven't mentioned much is something we've known for a long time in using tricyclic antidepressants, and that is there seem to be two different subtypes of tricyclic responders. Patients who are agitated or highly anxious and who seem to respond well to the more sedating tricyclics such as Sinequan or Elavil, and also the retarded depressive subtypes who seem to respond well to activating tricyclic antidepressants such as imipramine and desipramine. Yet it seems that DSM-III does include the criteria for making these diagnoses, and it's simply a matter of the treating physician understanding that once these criteria are met, applying the further refinements that the pharmacological data supports to his therapeutic management of the patient.
You know, I think what you have done is pointed out that some of the features of what has in the past been thought of as endogenous are much more powerful than others, and that some may have no power at all. So I guess my question is, if we took a fresh look at the subdivision of depressive disorder, well, I guess the first question is, have we made the entry too easy? Should we require even more than those 4 symptoms? Now, in requiring the original 4, we were merely asking, is a depressive syndrome present? And it seemed to us that that was a fundamental distinction, depressive syndrome versus depressed mood. Perhaps we have had too low a requirement there. Would you think we should require more than those 4?
I think it may just be important and suffice at this moment to alert the physician who will use DSM-III that some of the criteria do seem to be slightly more weighted than others in allowing them to select the pharmacological treatment of choice for that patient.
One of the features of DSM-III is the multi-axial approach to diagnosis, and in that approach we have several axes, and each patient is to be rated and considered on those axes. And the 2 axes which are relevant to this discussion is axis 1, which is the clinical psychiatric syndrome. That's likely to be the affective disorder. But axis 2 is personality. And we have separated the clinical psychiatric syndrome from personality, since personality frequently is overlooked when a patient has an acute depressive episode, either because the patient is so disturbed that information is just not collected in that area, or the clinician understandably in his diagnosis pays more attention to the immediate cause for concern. Now, our hope is that with the multi-axial approach, we will have more standardized information on the coexistence of a personality disorder, and I would suspect that patients who have a depressive disorder that is superimposed on a personality disorder, such as histrionic personality, are again the patients that in the past were referred to as atypical and maybe the ones who are more likely to respond to an MAO inhibitor.
It's interesting that the group of people that you just described as responding to MAO inhibitors seem to be consistent with a group of patients that Dr. Donald Klein has discussed over the past few years as responding to MAO inhibitors, and that is, or they are, patients with a disorder he calls hysteroid dysphoria. Now, however, this group of patients, who, let me describe those briefly, they have a chronic personality style which is, as you say, a hysterical personality type. The symptoms are often precipitated by current events, but not always. The patient is usually female, has a shallow mood, labile mood, and it seems to be dependent on external sources of approval. She is typically histrionic, flamboyant, seductive. She typically has few vegetative symptoms and remains active. Now, Dr. Klein suggests that these symptoms are secondary to a primary affective disorder and therefore are responsive to monoamine oxidase inhibitors as opposed to psychotherapy, the usual form of treatment for patients with this kind of problem in the past. This is not to be confused, however, with those patients who were originally described by West and Daly as having atypical depressive disorders. The major differences being that the West and Daly atypical depressions, as originally described, did not have a significant premorbid personality disorder. Premorbidly, they were supposedly in good shape, and that the onset of their problem was acute and related to some serious and significant traumatic event. So there seem to be two subtypes of people who respond to MAO inhibitors who supposedly do not respond to other types of antidepressants.
Right. I think using DSM-III terminology, I suspect that most of Dr. Klein's hysteroid dysphorics would be intermittent depressive disorders, and actually I've discussed this with him, and I think he's in agreement there. So what we're really saying is that the two categories of intermittent affective disorders and atypical affective disorders in DSM-III are probably categories that suggest that the usual tricyclic medication may not be as appropriate as a consideration of an MAO.
That sounds very reasonable.
Please turn to side 2 of this cassette for the second part of the program.
Maybe it'd be useful at this point to talk a little bit about how we would go about making a decision regarding the treatment of a patient given the diagnostic criteria in DSM-III and given the kinds of data that we've been talking about that have come out of the psychopharmacology research literature.
Fine. One of the features of DSM-III is that we've tried to approach the classification in the sense of a decision tree. That is, what is the first question one would ask? What's the next question? I would think the first question in a patient who presents with something that may have to do with depression, we would ask, is there a depressive syndrome? That would really be our first question. If a full depressive syndrome were present, we would then ask, is this associated with schizophrenia, in which case we would think of schizoaffective disorder. If it's not associated with the schizophrenic disorders, then presumably it's an affective disorder. We would then ask, are we dealing with an episodic affective disorder? That is, was the patient pretty much well prior to the beginning of this episode of illness? If so, we would then ask, are we dealing with a depressive disorder where the patient has had a previous episode? Is the current or previous episode limited to a manic episode? And has the patient had both manic and depressed episodes, in which case we would be dealing with a bipolar affective disorder? Could you say something about the considerations of electric shock therapy? Now, obviously, there are advantages to pharmacological treatment as opposed to electric shock therapy, but my understanding of the literature is that for severe depression, there is a lot of evidence that electric shock therapy might be more efficacious than pharmacological treatment.
Yes, I think that brings us into the next decision that we would come to, and that is if the patient does not have a bipolar illness, that patient may then have a depressive disorder which will respond to tricyclic antidepressants. Now, given the kinds of symptoms that we've talked about already, if, for example, if patients have unipolar depressions and if they have vegetative symptoms of anorexia, weight loss, middle or late insomnia, and psychomotor disturbances, that these patients most likely will respond well to tricyclic antidepressants. If they have an agitated or activated or anxious depression, they may respond well to the more sedating tricyclics, and if they have a retarded depression, they may respond well to the more activating tricyclics. However, if patients have delusions, hallucinations, or other psychotic symptomatology, the data seems to be fairly clear that these people will not respond well to tricyclic antidepressants. At that point, the data indicates that the use of ECT is probably the treatment of choice. The suggestion that we use antipsychotic agents at this point is generally a function of our reluctance to use ECT in younger patients, for example, who have their careers ahead of them and for whom ECT might be seen as a stigma. Younger patients who receive ECT are thought by some people to have more severe or a different quality to their disorders, especially lay people, and I think that the stigma attached is still such that there are some physicians who feel that the use of antipsychotic agents is preferable. However, again, I think the important factor to note is that the patient who has hallucinations, psychotic symptomatology, probably will respond best to ECT.
This might be a good time to talk about the whole issue of reactivity. That is, whether it's useful to subdivide depressive disorders on the basis of whether or not an identifiable psychosocial stressor has been identified. And you'll recall that in DSM-II, this actually was the way in which the major affective disorders were subclassified. You had the psychotic depressive reaction, in which presumably a psychosocial stress had been identified, and then you had the other involutional and major affective disorders where presumably this was not identified. Now, we have not maintained that basis, and we did that because our understanding of the literature was that major depressive disorders sometimes are associated with psychosocial stressors, and that feature did not seem to bear any relationship to outcome or to psychopharmacological management. And I gather that your review of the literature indicates that?
Yes, my reading of the literature supports your contention completely, that there does not seem to be anything that suggests that clear separation into endogenous or reactive types based on precipitants which have occurred in the individual's life. Rather, it seems that regardless of how the individual came to the final common pathway, if you will, of a biological depression, or using the old terminology, an endogenous depression, that has certain implications for diagnosis and, of course, secondly, for therapeutic management.
Finally, in DSM-III, there is a group of conditions that I don't believe we've mentioned, which are the adjustment disorders. And here, by definition, a psychosocial stressor is involved in the development of the episode of illness, and one of the most common forms of adjustment disorder is certainly with depressed mood. But by definition, we would not include any patient who had the full syndrome of the depressive syndrome. And I suspect that many patients who in DSM-II were diagnosed as neurotic depression, some of those will now in DSM-III be mild or maybe even moderate forms of depressive disorder, and some of them will be what we would now refer to as adjustment disorder.
I think that group of patients will also show less response to pharmacological management than the patients we've already discussed. However, I think that in some of these individuals, it may well be worth a trial on tricyclic antidepressants. It may also be very useful to remember that since they have a less well-defined disorder than the ones we've talked about before as being tricyclic responders, that they may require less medication, although they may still have a better response than if they were not treated at all with tricyclics. Unfortunately, there is not good data in the literature which shows that these individuals respond any better to tricyclic antidepressants than they would to placebos. That's an area that clearly needs more work. I wonder if you might comment a little bit on how the group of depressions which are superimposed on schizophrenia will be handled in DSM-III?
Right. Well, first of all, we assume that there are some patients in which the depression seems to be really part of the schizophrenic illness, and as we have conceptualized that, that is schizoaffective disorder. There we're talking about the psychotic symptoms and the depressive symptoms occurring roughly at about the same time period, and they're overlapping. One of the rather major issues that we thought we had resolved that we're now reopening because many people have suggested that we've made a mistake, is the whole issue of whether schizoaffective schizophrenia should remain within schizophrenia, as it is in DSM-III, or whether it should be given a separate status, since so much of the current literature suggests that at least acute schizoaffective may be more closely related to affective disorder. On the other hand, there are some patients who recover from a schizophrenic illness and are left with residual symptoms and then develop a superimposed depressive syndrome, frequently in response to some life situation. Now, it's never been clear how to diagnose such patients. This, we feel, is another example where the category atypical depressive disorder may be useful. We wouldn't want to call those patients depressive disorder because we think that probably it's a fundamentally different form of illness when it is seen in a patient who already has schizophrenia. I suppose logically speaking, there's no reason why an individual can't have the misfortune of having both schizophrenia and a major affective disorder, but at least in terms of our current understanding, it seems wisest that if a patient with a clear schizophrenic illness has a superimposed depression, that this is an atypical depressive disorder and should not be confused with the usual form of depressive disorder.
Would you see these patients as being any different from those individuals who are being currently discussed in the literature and described in the literature as having post-psychotic depressions?
I think we're talking about the same patients, yes. Frequently this is following the acute psychosis where the psychosis has remitted and either there is an interval where they merely have the residual symptoms or they go immediately into a depressive state. So I think the answer is yes, those are the same kinds of patients. It's another example where in DSM-III we've tried to bring into the official classification diagnostic concepts which have been around for a long time but have never made their way into the official classification.
I think that's a good idea because it's clear that in the past this particular problem has been overlooked to a certain degree by physicians and needs particular attention. It's unfortunate that we, at least in my current reading of the literature, don't have a very good feeling for how to treat patients who suffer from this particular syndrome.
I wondered if I could ask, what is the current view about the danger of giving tricyclics to a schizophrenic in the sense of reactivating the psychotic process?
I think in the absence of an antipsychotic agent, one is always somewhat concerned about giving a tricyclic to a schizophrenic patient. My feeling, again from reading the literature, is that it may be that the activating tricyclics, such as imipramine and desipramine, may be more harmful in this regard than the sedating tricyclics, such as doxepin and amitriptyline. But given conjointly with the antipsychotic agents, I think there is a place for the use of the tricyclic antidepressants in the treatment of patients who have significant depressions which accompany a schizophrenic process.
We at the Pfizer Laboratories division of Pfizer Incorporated, manufacturers of Cinequan, doxepin hydrochloride, have been happy to bring you this audio cassette program. The opinions expressed in this program are those of the physicians involved and do not necessarily reflect those of Pfizer Laboratories. Cinequan, doxepin hydrochloride, is a tricyclic antidepressant available in 10 milligram, 25 milligram, 50 milligram, 75 milligram, and 100 milligram capsules, and in 10 milligrams per milliliter oral concentrate form. Cinequan is contraindicated in individuals who have shown hypersensitivity to the drug, and in patients with glaucoma or a tendency to urinary retention. The once-a-day dosage regimen of Cinequan in patients with intercurrent illness or patients taking other medications should be carefully adjusted. This is especially important in patients receiving other medications with anticholinergic effects. The use of Cinequan on a once-a-day regimen in geriatric patients should be adjusted carefully based on the patient's condition. Since there is no experience in pregnant women who have received this drug, Safety in pregnancy has not been established. The use of Cinequan in children under 12 years of age is not recommended. Serious side effects and even death have been reported following the concomitant use of certain drugs with MAO inhibitors. Therefore, MAO inhibitors should be discontinued at least 2 weeks prior to the cautious initiation of therapy with Cinequan. Since drowsiness may occur with the use of this drug, patients should be warned of this possibility and cautioned against driving a car or operating dangerous machinery while taking the drug. It should be borne in mind that alcohol ingestion may increase the danger inherent in any intentional or unintentional Cinequan overdosage. This is especially important in patients who may use alcohol excessively. Since suicide is an inherent risk in any depressed patient, patients should be closely supervised during the early course of therapy. The following adverse reactions have been reported and should be considered when prescribing tricyclics, including Cinequan: dry mouth, blurred vision, drowsiness, urinary retention, constipation, skin rash, dizziness, nausea and vomiting, and raised or lowered libido. With respect to the cardiovascular system, hypotension and tachycardia have been reported occasionally. The usual starting dose is 25 milligrams TID, with a maximum of 300 milligrams per day. As an alternative regimen, the total daily maintenance dosage, up to 150 milligrams, may be given on a once-a-day schedule without loss of effectiveness. This dose may be given at bedtime. Full prescribing information for Cinequan, doxepin hydrochloride, accompanies this cassette recording.